So Dr. Yatavelli is going to be doing his talk about pediatric endocrine emergencies, hypo and hyper. All of us in this room will be exposed to one of these conditions. So it's a very good talk, and I'm looking forward to hearing what he has to say. So let's see what he has.
Thank you. Good morning. Is it clear? Yeah. Okay. Right. So I'm Dr. Yatavelli. I'm one of the MedPeds fourth year resident. Today I'm doing my grand rounds. And when I was thinking about what to do about grand rounds, I'm doing my endocrine fellowship starting in July. So I thought it would be better to do something related to endocrine. And when I was thinking, we see a lot of endocrine emergencies in pediatrics. Some we get comfortable as we go through our training, like DKA and hyperosmolar, which we see in and out, and by the end of your residency we are all pretty much comfortable dealing with them. But there are some other emergencies which we see every now and then, which are rare but not uncommon, and I thought that it would be good to talk about those today. So I have no disclosures to make. And my objectives today would be first to recognize the signs and symptoms of common endocrine emergencies and initiate diagnostic evaluation, to determine and obtain critical and archival labs prior to initiating treatment, and describe the appropriate life-sparing treatments directed at correcting abnormal signs and lab abnormalities when we encounter the endocrine emergencies. So endocrine emergencies are many, we can go through like glucose, hypoglycemia, hypoglycemia, disorders of adrenal insufficiency or adrenal excess, disorders of sodium and water imbalance, disorders of thyroid, hypo or hyperthyroidism, disorders of parathyroid and calcium, disorders of the pituitary, today I would just like to concentrate more on glucose, adrenal, thyroid, and sodium and water, which we see more often in our regular hospital and even in our practice outside. So all the endocrine emergencies manifest in a wide variety. Some of them have, it may be just the initial manifestation of the disease, or it can occur in setting of intercurrent illness, or if you are going through any stress or non-compliance with medications in patients who already have known endocrine disorders. So usually the signs of endocrine emergencies are very vague, and they might present as any other illness, like you can present with lethargy, weakness, you can have altered mental status, seizures, general signs like small respiration, poor feeding or weight loss, or it can present with shock, hypotension or tachycardia. They can present in any way. It could be very confounding and really needs a little bit of more in-depth thinking to diagnose the emergencies properly. First, I would like to, and since the signs and symptoms are so varied and non-specific, and it might lead to delayed or misdiagnosis if not seen properly, and the prompt diagnosis mostly depends on the collection of critical and archival samples before initiating any treatment. What I mean by critical or archival samples is, critical samples is the blood lab levels which we take it as soon as see the patient, and the values which we get back immediately, like the BMP, the glucose, the CBC. Archival samples are you take the blood at the same time but store it, refrigerate it, or send it to the lab and keep it aside, so that when we talk to the specialist or when we get to narrow down our spectrum, we can send it for reference labs or some other investigations which could help us more in the diagnosis of the disorders. Because once we have started treatment, it's it's very unlikely that we can go back and get back the same sample. So this applies to like any kind of any pediatric patient presenting to the ERs, so that we avoid like numerous sticks to the kid. So first I'll go through like the disorders of glucose. Hyperglycemia and DKA is more common, which we see very often, and we all know the management like fluids, insulin, collect the correct abnormalities. But hypoglycemia is one which when we see, we really don't know what, at least I wasn't so comfortable like to managing, to give glucose, but like what's causing the hypoglycemia. So no definite cutoff values have been identified for like low glucose levels. In children and older adults, like at least 60 milligrams per deciliter is the accepted value, and on kids who are on insulin or insulin dependent diabetes, in them 60 can be considered as cutoff. But when it comes to newborns and neonate, the topic is much controversial and debated. Like for centuries, it's been like 40, some say 30, 45. So the values are very arbitrary. The reason being, when newborns are born, like at least for the first 24 to 48 hours, the blood glucose level sometimes is expected to go low, but the newborns have this metabolic adaptation where they use their body fat or their ketones to generate glucose and provide energy to the brain. So the values have been, so no definite cutoff values have been defined so far. But any hypoglycemia persisting more than 48 hours is considered as like true neonatal hypoglycemia, which needs to be investigated thoroughly. So as per the AAP 2011 guidelines, no cutoff for there was no cutoff defined for safe or unsafe values for glucose values, and routine screening and monitoring is indicated only for at-risk infants. What they mean by at-risk infants is infants of diabetics mother, small for gestational age babies, large for gestational age babies, and late preterm. And they say like any infant with a blood glucose less than 45 milligrams per deciliter and who are symptomatic should be treated with IV glucose immediately. So a cutoff value as per 2011 was 45. It might have changed now though. So this is a slide from the 2011 guidelines where they say that like the at-risk infants, as I mentioned, the sought for gestational age, the infants of diabetic mothers, and late preterm infants, if they are symptomatic and if the blood glucose is less than 40, you go ahead and treat them. But if they are asymptomatic, then if at least up to first 4 hours of age, you try to feed the baby within the first 1 hour and screen for the blood glucose after the first feed. If the initial screening of the blood glucose is less than 25, then you feed and recheck in 1 hour. If it is less than 25, then you go ahead and give IV glucose. If it is 25 to 40, they say refeed and IV glucose as needed. But if it is 4 to 20, at least after 4 hours, then they said continue the feeds every 2 to 3 hours and screen if less than 35. And if it is less than 35, then feed and recheck in 1 hour. If it is still less than 35, then you go ahead and give IV glucose. And if it is 35 to 45, then you just refeed or you can do IV glucose as needed. But say like if there is persistent hypoglycemia for more than 48 hours, then that should be investigated, and you can refer to the endocrine specialist. This was a recent article which I found in New England Journal. It was a prospective study done in New Zealand where they enrolled like 528 neonates who were at risk for hypoglycemia. The criteria being the same, like late preterm, infant of diabetes, small for gestational age, and they were so their cutoff value was 47 milligrams per deciliter, and they measured like continuous interstitial blood glucose for 7 days, and then which was blinded to the nurses and to the staff, and the intermittent capillary blood glucose was measured. So, and anything less than 47 they treated, and it was followed for 2 years. So they monitored the blood glucose for 7 days, and at the end of 2 years they did a developmental scale and visual and executive function of the kids who had less than 47 and more than 47. But interestingly, they said that like neonatal hypoglycemia was not associated with any adverse neurological outcome, and when the glucose was around 47 milligrams per deciliter. So do we consider 47 as the new number? Maybe, maybe not, but it's near around. But one more interesting point in this study was like those who had like higher blood glucose levels, like those who had like 100, 105, they commented that like they had a poorer score on the behavior and development, but it might be confounding factor, so we should not go by it. And this is an ongoing study, and they said they are looking at like 4 and 5 years too from now to see how the kids are doing. So moving on, so the causes for neonatal hypoglycemia, like those who are persistent beyond 48 hours. So initially, like it could be because of hyperinsulinism, like transient in diabetic mothers or small for gestational age. But those who are persistent, it could be due to hyperplasia of the islet cells. In any infection can cause hypoglycemia. Inborn errors of metabolism, your glycogen storage diseases, all your inborn errors can cause hypoglycemia. And hormone deficiencies like adrenal insufficiency, your growth hormone deficiencies, and liver failure due to any cause can lead to hypoglycemia. Coming to older children, like more than 1 year, or toddlers and your adults, mostly if they are insulin dependent, it could be because of insulin induced, or it could be surreptitious ingestion of insulin, or oral hypoglycemic drugs, or illicit drug use. Infection, malnutrition, anorexia, bulimia, alcohol or salicylate intoxication, and liver failure can cause hypoglycemia in older adults. And some inborn errors of metabolism could present later, and they can cause hypoglycemia. Ketotic hypoglycemia, this is one more interesting cause which is seen more commonly in older children around like 4 months of age to at least 4 years of age, 10 months of age to 4 years of age. So after like less periods of fasting, kids go into hypoglycemia. They get sweating, anxious, tremor, and all the hypoglycemic symptoms, and once they are feeded, they come back normal. But most of them, they outgrow by 8 years of age, and it is considered like one of the most common reasons you see in kids with hypoglycemia. So the symptoms, like when you get hungry, you get shaky, you get heartbeat, you get neurogenic symptoms, you get hyperadrenergic symptoms, blurred vision, you can get seizures, you can have syncopal episode. So lab evaluation, as we spoke earlier, critical samples and archival samples. Critical samples is the samples which helps you determine what's happening right then and there. So we get a bedside glucose stick, serum glucose, you can get a CMP and a urine analysis. Archival samples are the samples which you obtain and then keep it aside or send it to the lab to be refrigerated, and then you do further workup depending on your initial assessment or in consultation with the specialist. So we look at like insulin and C-peptide. Insulin to see if they are hyperinsulinoma. C-peptide, it helps you determine if they are like if insulin has been given for, if there is any surreptitious injection of insulin. Ketones, lactate, growth hormone and cortisol help in glucocorticoid deficiencies. Carnitine profile to look for any of the metabolic errors. Amino acids to help us in inborn errors of metabolisms, and then toxins and urine for organic acids and UDS. So all this should be obtained and kept aside, and then we should move further. Treatment is IV glucose. 0.2 to 0.3 grams per kilogram is the recommended dose. If you just simplify it, if 10% dextrose, you can give 2 to 3 ml per kilogram. That would provide you enough glucose for the hypoglycemia. In refractory cases, you can use glucagon, especially in patients on insulin who go into hypoglycemia. You can do like 0.5 to 1 mg IM or IV. And all our insulin dependent patients who are on insulin should have a glucagon kit with them, and the mom or the dad or the caretaker should know how to administer the glucagon kit. And in refractory cases, we can use hydrocortisone that can raise the glucose. Hyperinsulinism, it's a specific treatment, diazoxide, 10 to 15 mg per kg per day, but as pediatrician, we rarely start this. We will normally refer it to the specialist, and they take over from there and evaluate and correct if any underlying abnormality, like if you see any sepsis or if you have any hormonal deficiencies, we need to address that before. Next, let's talk about adrenal. So adrenal insufficiency, it's not rare, but it's not uncommon too. So we see every now and then adrenal insufficiency, especially. Okay, and so it could be divided into like newborn period and children who are grown up. In newborn period, congenital adrenal hyperplasia is the most common cause of adrenal insufficiency, and in kids, in toddlers and kids and adolescents, those are on long-term steroids, the sudden discontinuation of the medication, or those who stop taking the medications, vomiting or any stressors or infection could precipitate an adrenal insufficiency. Other rare causes are like you have your intracranial abnormalities of empty sella syndrome or septo-optic dysplasia, where you have pituitary abnormalities, and it will be a central adrenal deficiency. Your tumors of craniopharyngioma or trauma or irradiation to the head and neck can cause pituitary problems that in turn can cause adrenal failure. Autoimmune polyglandular disease, Addison's disease is also a common cause of adrenal insufficiency. Infections wise, tuberculosis and histoplasmosis can cause adrenal infection and adrenal insufficiency. So briefly going through the physiology of adrenal glands, we all have read in our med schools. It's made of outer cortex and inner medulla. It basically produces glucocorticoids and mineralocorticoids. So cholesterol get converted to pregnenolone, and then pregnenolone converted to progesterone. Cortisol is your main glucocorticoid, and aldosterone is your main mineralocorticoid. Excuse me. Adrenal medulla produces adrenaline and noradrenaline, which are the catecholamines, and it's called the fight and flight hormone. So adrenal glands respond to stress. So in acute stress, the catecholamines get released, and what they do, epinephrine and norepinephrine, they break down glycogen, increase your blood glucose, increase blood pressure, increase your heart rate, increase your metabolic rate, and change in the blood flow patterns. But if in long-term stress, then the glucocorticoids and the mineralocorticoids, glucocorticoids like cortisol and mineralocorticoids aldosterone. Aldosterone works via the renin-angiotensin-aldosterone pathway. It increases your sodium absorption, water retention, and maintains your blood pressure. And glucocorticoids help in gluconeogenesis from the fats and the proteins. So when you have adrenal deficiency, we see you do not have good response to stress. So you might go into hypotension, you might have salt loss, sodium loss, fatigue, and all the symptoms of adrenal insufficiency, and you might go into shock, which might be similar in presentation to sepsis or any hypovolemia. So clinically it presents as dehydration secondary to your volume loss, hypotension secondary to sodium loss and loss of your aldosterone activity, hypoglycemia as there is no cortisol or glucocorticoid activity. And because of all this, it can precipitate altered mental status. And newborns normally present with failure to thrive, present in hypovolemia or shock. And in congenital adrenal hyperplasia, we can see virilizing signs, especially in females. They can have clitoromegaly or ambiguous genitalia, which might be a clue to your adrenal insufficiency. So congenital adrenal hyperplasia, it's one of the most common causes of primary adrenal insufficiency in the newborn period. The most common enzyme deficiency is 21 hydroxylase, but you can also have your 11 and 17 hydroxylase deficiencies, but they are much rarer. 21 hydroxylase accounts for 90% of the case, and as I said earlier, females with the presence with virilizing signs, males do not have a specific stigmata, and presenting with failure to thrive can be easily missed. Although newborn metabolic screen looks for congenital adrenal hyperplasia, it's a screening test and there is always a chance for error. So if you suspect, you always have to go back and look into it. In older children, most commonly it is seen in steroid dependent children, like kids who have autoimmune diseases who are on long-term steroids, oral steroids, kids who had organ transplants who are on long-term oral steroids, asthmatic children who are on inhaled corticosteroids, or chronic asthmatics who have poor control and who use pulse doses of steroids very frequently. So in them the crisis is most commonly observed. So this was an article which was published in the European Journal in 2015. It was a retrospective study where it was done in Germany, where 2,300 patients, asthmatics, who were on inhaled steroids or oral steroids, were retrospectively seen back. They had synactin stimulation test to see if they had adrenal insufficiency, and interestingly 20% of the patients on inhaled steroids failed the test, and which indicated that they are at risk for adrenal insufficiency. So not only those who are on oral steroids, but those who are on high dose of inhaled steroids at risk for getting adrenal insufficiency. And there was one more article which looked at 143 children on inhaled steroids, and they observed that those who are on inhaled and nasal steroids combined had lower cortisol, serum basal cortisol levels when measured at 2 years. So children with asthma or allergic rhinitis who are on both steroids, then we need to be a little bit more cautious, especially when they present with any of the symptoms of adrenal insufficiency. Excuse me. And the lab evaluation, like in suspected adrenal crisis, as I mentioned earlier, the critical samples like BUN, your glucose, your CMP, and plasma renin should be obtained. And archival samples are the ones which we send off, like cortisol, ACTH, 17-hydroxyprogesterone, and free T4, TSH if you suspect a hypopituitarism. So what do you see in adrenal insufficiency? So you do not have aldosterone, so you have sodium loss, so you go to see hyponatremia, hyperchloremia, you have hypoglycemia, hypochloremia. So they normally have normal anion metabolic acidosis, which is a clue to suspect that they might be having an AI. So your simple CMP would give you a lot of information actually when they present in hypotension or shock, or those who have vague symptoms. What do we do when we say that they have adrenal crisis? So initially present in hypovolemia, you do your ABCs of resuscitation, airway, breathing, circulation should be managed, and then give IV fluids, like can give 20 ml per kg of normal saline bolus. Repeat it as needed and more frequently until you attain the blood pressure. And 10% dextrose can be used to increase your blood glucose levels. And IV hydrocortisone, 25 to 50 milligrams per meter square, or if one is simply could give like 2 to 3 mg per kg of IV hydrocortisone. IV hydrocortisone has both glucocorticoid and mineralocorticoid effect. So if you are using IV hydrocortisone, then that's much easier and faster. But if you are using dexamethasone or methylprednisone or prednisone, then it should be supplemented by fludrocortisone, because dexa, meth and prednisone do not have the mineralocorticoid effect. And so adrenal crisis, you have sodium loss, potassium retention, and then the potassium can go very high. It can go up to as high as 6. So, and if it goes more than 6, then you all know that like we are at risk for cardiac arrhythmias. So it should be managed, and then get an EKG stat, look at it, give sodium bicarb to stabilize the cardiac membrane, or calcium gluconate over 10 to 15 minutes. And dextrose plus insulin can be given, 10% dextrose plus insulin can be given to temporarily, it causes the potassium to shift from intracellular compartment. But for definitive treatment, you need to give Kegslate either orally or rectally until a bowel movement, you see a bowel movement, and then the hyperkalemia is corrected. Moving on, talk about a little bit about hypo and hypernatremia. We see it very common, one of the most confusing ones though. So hyponatremia and hypernatremia mostly we see because of dehydration, GI losses. Those are the most common causes, and kids with vomiting, viral gastroenteritis, or post-operatively, we see hyponatremia and hypernatremia, and it's easily correctable with IV fluids. It's just your basic rehydration. But what I'm going to concentrate now is more on diabetes insipidus, SIADH, and cerebral salt wasting, which we see not so often, but every now and then. So diabetes insipidus is secondary to ADH insufficiency or ADH resistance. ADH is your antidiuretic hormone, which is produced from the pituitary, and it acts at the kidney level, helps in retaining water, free water. So in central DI you have ADH deficiency, and in nephrogenic DI the ADH is there but the kidneys don't respond, and most DIs present, diabetes insipidus present with polyuria and polydipsia would be the initial presentation. So kids present with like excessive thirst, lot of urine, dehydrated, fatigued, looks similar to diabetes mellitus, but blood glucose values are normal. Other things which can present with polyuria and polydipsia can have hypercalcemia, which presents with polyuria, polydipsia, and then your primary polydipsia and psychogenic polydipsia can have similar presentations. So looking at the causes for DI in children, the central causes, mostly it's related to pituitary. It could be because of some tumors like craniopharyngioma or germinoma, trauma, infections, any encephalitis, meningitis can precipitate DI, autoimmune causes can cause, drugs, alcohol, phenytoin is known to cause, and Langerhans cell histiocytosis, the rare one which can cause DI too. The nephrogenic diabetes insipidus is mostly familial. You have a family history of someone having DI, hypocalcemia, hyperkalemia, and renal disease like polycystic disease. Sickle cell nephropathy can cause DI, and drugs. Lithium don't use much in pediatric population, but amphotericin B sometimes we use for like invasive fungal infections can precipitate diabetes insipidus. As I mentioned earlier, the signs are mostly polyuria, polydipsia, kids presenting with nocturia, new onset bedwetting, dehydration, poor growth, and presenting with any history of any recent CNS insult like a trauma, tumors, or infection should raise the suspicion for DI. So the physical findings mostly reflect the volume contracted state of the diabetes insipidus, present with dry mucous membranes, sunken eyes, tachycardia, and decreased skin turgor. Hypernatremia is seen, which can cause increased tone, brisk reflexes. Vision may be impaired in those with intracranial tumors because they can have coexisting pituitary anomalies, like they may have like growth hormone deficiency if there is pituitary tumor or a hypothalamic tumor which is compressing and causing both DI and other pituitary anomalies. So the critical samples, so BMP would tell you your sodium, your BUN, creatinine values, mostly it's hypernatremia which you see. Serum osmolality should be obtained, urine analysis, urine specific gravity, and urine osmolality. So basically in diabetes insipidus you have loss of lot of free water. So you lose lot of free water and all you have is just sodium. So you expect your increased sodium, your serum osm to be higher because you have more sodium, less water. And in urine it's more diluted, you will have more water. So you see like a dilute urine with urine specific gravity less than 1005. Urine osmolality is less too, like less than 300, and you have large volumes of urine output. Treatment of DI, like if it is central DI, desmopressin is the drug of choice, and in nephrogenic DI, hydrochlorothiazide. But these are start to use this once the diagnosis is confirmed and then in consultation with the endocrinologist. But before that, like when we see hyponatremia, then our goal should be initial correction with IV fluids, and the correction should not be more than 0.5 milliequivalents per liters per hour. So I can use hypotonic fluid like 10%, 5% dextrose, or quarter normal saline or half normal saline to correct the hypernatremia. If it is too high, like 160s, or then you can use free water like dextrose, or if it is around 145, 150s, you can use quarter normal or half normal saline. But need to be cautious, like those who present with hypernatremic dehydration, they have loss of both free water and in general they lose sodium and water too. So goal is to resuscitate both of them. So you need to correct free water with your dextrose or quarter normal saline, but at the same time his whole water and salt deficit should need to be corrected too. You can use bolus of plasma light or your normal saline. Excuse me. Hyponatremia, we see it more often than hypernatremia. So when we see hyponatremia, any lab anomaly like as hyponatremia, the first step would be to assess the volume status, because that would guide the whole pathway of like what is causing the low sodium. So assessing the volume status is the first step, and then you classify them as either hypovolemic hyponatremia, either they are euvolemic or if they are hypervolemic. And after you assess that, you can obtain your critical samples like CMP, your urine studies, your urine osmolality and serum osmolality. Hypovolemic hyponatremia is by far the most common hyponatremia which we see, most commonly due to GI losses like vomiting, diarrhea, gastroenteritis. kids on diuretics like furosemide or thiazides, they cause sodium and water loss. Addison's disease, that also causes hypovolemic hyponatremia, and some salt wasting nephropathies can cause hypovolemic hyponatremia. So when you see hypovolemic hyponatremia, the fix is you just need to fluid resuscitate them and correct the hyponatremia. Euvolemic and hypervolemic hyponatremia in kids is seen in kids who have other underlying anomalies, like kids with renal failure, those who have like volume overload, kids with cirrhosis, those who have volume overload, those with congestive heart failure or water intoxication, and kids with hypothyroidism or SIADH, they present with euvolemic or hypervolemic hyponatremia. Pseudohyponatremia is another entity where you see sodium level is low, but it is not truly low, like as in your diabetes. When your glucose is high, so you need to correct for the correction factor, and like hyperlipidemia and hyperproteinemia, where the number of osmoles from the lipids and the proteins are more, which causes sodium to be spuriously low. So lab evaluation, so the critical samples include your BMP, you need to obtain serum osmolarity that will tell us like if it is hypo or hyperosmolar. UA would guide you a lot whenever any kid or even adult presents with dehydration or any hyponatremia. If it's the specific gravity will give you an idea, the urine pH, and then urine lights will give an idea of how much salt they are losing and how much chloride they are losing, and urine osmolarity would also help you. Then archival samples can be obtained, kept aside to look if they have, because hypothyroidism is one of the cause for hyponatremia, and low cortisol levels can cause hyponatremia, ADH, TSH. So these samples can be obtained and then sent off if needed at a future date. So syndrome of inappropriate diuretic hormone and cerebral salt wasting are other two entities which can cause hyponatremia. Basically, SIADH is an uncommon entity compared in children when compared to adults. And cerebral salt wasting, it's a relatively new clinical entity which is being described more often, and it is being seen more often too, because, and I'll talk a little bit more about it as we go on. SIADH is basically due to excess of your antidiuretic hormone. So you have more antidiuretic hormone action, and so you have more free water retention. So basically you get into hypervolemia and then you get hyponatremic. So SIADH in children, it can be caused by any insult to your CNS, like infection, like encephalitis, meningitis, trauma, intracranial tumors. Any lung infections or cancers can cause SIADH, like pneumonia, tuberculosis, positive pressure ventilation. Kids in PICU on long-term mechanical ventilation, they are at risk for SIADH. Medications, desmopressin, it's an ADH analog used to treat nocturnal enuresis sometimes. So if they are taking more of it, they can present with SIADH. And some chemo drugs, basically the most commonly used vincristine, vinblastine, and cisplatin are known culprits of causing SIADH. And anticonvulsants, carbamazepine, we are backing off now because of the newer anti-epileptics, but still there are a lot of kids on carbamazepine, and it is known to cause SIADH. And valproic acid and your trileptal can cause, and SSRIs, tricyclic antidepressants, are also some of the drugs which are known to cause SIADH. There's a long list, so whenever you see SIADH, look for the causes. If not, then look at what are the drugs and if the patient is on one of those drugs which might be contributing to the SIADH. So how do we diagnose SIADH? So the first thing is like they should be hyponatremic and can be a chronic or acute hyponatremia. The first thing we need to make sure is that he is euvolemic, I mean it's not hypovolemic. If it is hypovolemic, you cannot make a diagnosis of SIADH. Kids presents with hypovolemia, correct the hypovolemia, then euvolemic, and then repeat the labs. Because of because of excess ADH and excess water, your serum os will be low, and you will lose sodium in the urine. So urine sodium will be more, and urine osmolarity, because you have like a lot of water retention and you send off more of sodium. You see that urine osmolarity is more than the serum osmolarity, but you have to make sure that there is no renal problem, there is no adrenal problem, there is no thyroid or dehydration which is contributing to this. That's the reason we get your TSH, cortisol and other labs before classifying them as having SIADH. Cerebral salt wasting, this is a new entity which is defined more now. It has characteristics of both DI and SIADH. So it occurs mostly after a CNS insult, like kids who undergo trauma, or they had a brain surgery, or they had a head injury. So it occurs after a week after the CNS insult, and it may last for 2 to 3 weeks. So what they see is like loss of excess water, like diabetes insipidus, they lose a lot of water, and at the same time they lose a lot of sodium, like SIADH, even though they are hypovolemic and hyponatremic. So normally when you have hyponatremia, you try to conserve sodium, but in cerebral salt wasting, you lose both water and sodium despite being hypovolemic and hyponatremic. It is thought to be caused by atrial natriuretic peptide, which decreases the reabsorption of sodium in kidney. So how do we differentiate between cerebral salt wasting and SIADH? So in cerebral salt wasting, there is a lot of volume loss. So you see that the plasma volume is decreased, so they are hypovolemic. But SIADH, they need to be U or hypervolemic. Urine sodium is highly increased in salt wasting because you lose a lot of sodium. But in SIADH also it is increased, but not as much as urine sodium. Urine volume is increased in cerebral salt wasting, but in SIADH the urine volume is decreased. You don't make a lot of urine, but this one resembles more of DI. And if we look at the labs, ADH is normal here. We don't normally routinely check ADH levels because it has to be sent off like right then and there, and so it's done very rarely. And the treatment basically for SIADH, the treatment is fluid restriction. But in cerebral salt wasting, you need to do fluid and sodium should be replaced because they are hypovolemic and hyponatremic. So I'll go through management of hyponatremia. Acute is like if they have acute hyponatremia which is less than 2 days duration. It could be because of any cause like GI losses, or because of SIADH, or because of your cerebral salt wasting, and they present with sodium of less than 120. So less than 135 is your definition of hyponatremia, but less than 120 is more critical, because once the sodium goes below 120, the chances of having seizures are more. So it's usually due to hypervolemic hyponatremia, most commonly due to polydipsia, where you drink a lot of water, or excess hypotonic IV fluids post-operatively. We do not see a lot of this here, but in literature it is reported that it is very common. Probably, I mean, here all the post-op patients are managed by pediatricians, so we look after their fluids and we make sure that like they are not getting excess or less of hypotonic IV fluids. The treatment, we can use 3% hypertonic sodium chloride, or you can use normal saline too, but if it is less than 120 and if it is acute, 3% is indicated. 3% sodium chloride has to be given through a central IV line. It burns your veins out. It has to be given in a PICU setting. If you give it at 1 ml per kg per hour, it increases the sodium by at least 1 milliequivalent per liter per hour. And we should be cautious that the sodium should not be increased by no more than 8 to 10 milliequivalents in a day, or else there is always a risk of your central pontine myelinosis and cerebral edema. And once the sodium is corrected to 125, and where it is more safe, 125 to 130, you can fluid restrict them if they have SIADH, and then that could correct the sodium further. In hypovolemic hyponatremia, as we mentioned earlier, isotonic saline is the most commonly used, your 0.9% normal saline. Chronic hyponatremia is like more than 2 days duration, and in patients with sodium less than 120 or those who are symptomatic. The management is similar, but the correction of the sodium is a little bit slower. You can do at 0.5 mils per kg per hour, and then once it reaches 125 you can use your isotonic saline or your fluid restriction. So SIADH, the main treatment is fluid restriction, and if it doesn't help then you can use IV Lasix followed by you measure your urine sodium and replace the urine sodium as much as it is lost. There are other drugs like Convaptan and all which are used in adult population, but I don't think we use much in kids. So cerebral salt wasting, the most is like vigorous fluid and salt replacement based on the urine output and urine sodium measurements. So I'll talk really quick about thyroid disorders in children. It's not as common as in adults, but we see a few cases of neonatal thyrotoxicosis and then Graves' disease and hypothyroidism in children and adults. So hypothyroidism, it could be divided into congenital and acquired. Congenital is one which you see it as soon as they are born. It's due to inadequate thyroid hormone at birth. Most of them are screened at birth, so we rarely miss congenital hypothyroidism now. It was once one of the leading causes for mental retardation. Acquired occurs after 6 months of age. Congenital hypothyroidism, it's still seen like 1:3,000 to 1:4,000 newborns, and females are more commonly affected than males. Most commonly due to ectopic thyroid tissue or a dysgenetic thyroid hormone. As mentioned earlier, newborn screen detects most of the cases, but if you suspect, recheck thyroid levels. Congenital hypothyroid, the presenting symptoms, kids have delayed jaundice, prolonged jaundice, protuberant abdomen. You may see constipation, coarse facial features, lethargy, hypotonia. Those are some of the clinical clues which point to congenital hypothyroid. Acquired, most commonly Hashimoto autoimmune thyroiditis. So whenever they have diabetes mellitus, you always like one autoimmune. If someone has one autoimmune disease, there is a chance that they get another autoimmune disease. So Hashimoto's, and it is increased incidence in Downs, those who have Klinefelters or Turners. Surgery or radiation to the neck can cause acquired hypothyroidism. Some medications like lithium and amiodarone is known cause. And late onset congenital hypothyroidism, iodine deficiency rarely seen in here, but still seen in some of the other countries where we do not have iodine supplementation in the salt. And secondary or tertiary causes like the CNS and tumors and your cranial irradiation can cause acquired hypothyroidism. So they can present with all the hypothyroid features like delayed growth, weight gain, constipation, dry skin, cold intolerance, or menstrual irregularities. Treatment basically is to restore euthyroid state as possible. Treatment is simple levothyroxine. The dosage of levothyroxine we can always look, but the reason I put it here is like the requirement is more when you are young, and then it decreases as you grow because your metabolic activity is more when you are young. So if we miss hypothyroidism here, you see more severe deficits and you see it like very quick, but adults can present a little bit later. Hyperthyroidism, it's much more rarer than hypothyroidism. It can be divided into congenital and acquired. Neonatal hyperthyroidism, it's mostly due to the transplacental passage of the thyroid immunoglobulins in mothers with Graves' disease who are on treatment now or who had treatment in the past. The prevalence is less than 2%. It usually presents in few days after the birth. Symptoms may be delayed for a week or more if mother is on antithyroid medication. So moms with Graves' history, treatment of thyroid, or those who received radioactive iodine in the past, we need to be cautious. Sometimes mothers don't tell you that they are radioactive iodine, and you see a kid who is jittery and all, you need to suspect that they might have hyperthyroid. It's typically transient in nature because once the immunoglobulins go, they become better, and it remits in 8 to 20 weeks, but it can cause prolonged intellectual impairment. So most commonly they can present with exophthalmos as a result, poor feeding, poor weight gain, tachycardia. They can present with CHF, abnormal stare or gynecomastia. Acquired hypothyroidism, like in the older adults and adolescents, most commonly due to Graves' disease, thyroiditis, like infectious, and it could be factitious due to accidental ingestion of thyroxine. Some diet pills have thyroid hormones, and they can cause hyperthyroidism. McCune-Albright syndrome most presents with thyroidism sometimes, and iodine-induced hyperthyroidism, we don't see it much often here. The symptoms are all the hypothyroid features like restlessness, fatigue, irritability, decreased school performance, as you can see, goiter. They can have tachycardia, weight loss, tremors. Thyroid storm is a medical emergency which is rarely seen in children, but it can be fatal if it is not diagnosed. They can present with high fever, tachycardia, arrhythmias. Most commonly atrial fibrillation is seen, congestive heart failure, agitation, delirium, seizures. When you see a thyroid storm, it needs to be managed. They have to be admitted to ICU. You cool them down with acetaminophen or cooling blankets, IV rehydration, and then beta blockers can be used for heart rate control. IV esmolol or IV propranolol can be used. Propylthiouracil or methimazole, these are the anti-thyroid drugs. They suppress the release of preformed thyroxine. And Lugol iodine can be used. Iodine binds to the thyroid hormone and decreases the further release of the thyroid hormone, but it has to be used only after you use methimazole. And steroids to support your adrenal. And the long-term management basically is like either anti-thyroid drugs or radioactive iodine or surgery. 3 options are available, but it's always refer them to the endocrinologist, and the parents have a talk with them, and then they decide what to do. So coming just to summary, so endocrine emergencies, they are rare but not uncommon. Then persistent hypoglycemia in neonates should always be referred to a specialist and evaluated. And we need to be watchful for adrenal insufficiency in kids on long-term oral or inhaled steroids. And sodium imbalance or water imbalance should be evaluated and managed thoroughly. Neonatal thyrotoxicosis can be seen in mothers who had treatment for Graves in the past, so always be watchful. And newborn screening test is just a screening test, so if you doubt hypothyroid, then always to rule out congenital hyperthyroid, the thyroid function test needs to be repeated. And I think that's it. Thank you. If you all have any questions. It was a long presentation, but it took long. Thanks.